So here I am again to talk to you today about cardiovascular medications. Let's begin with medications for angina. So we talked a whole bunch about this yesterday, and now we're just going to kind of review and focus more on the medications. So here's just a little review of the things that are operating on the heart that affect heart output and just generally cardiovascular function, such as the heart rate, which controls how much blood moves around, Starling's law, which affects how much contractility there is in the heart. Preload is the amount of blood pouring in, which stretches the ventricles, and afterload is the blood on the outside of the heart that's resisting blood leaving the heart. So, we can think about the forward and backward effects. Stroke volume. Control of blood pressure is primarily through the autonomic nervous system, the baroreceptors, the RAS system, renal water retention, and natriuretic peptides that we will talk more about. So, angina, what is it? It is a sudden pain beneath the sternum. It's a chest pain of various descriptions. It's caused by oxygen supply to the heart, which is insufficient to meet oxygen demand. It is the usual cause is hardening of the arteries, hardening of the arteries of the heart, which are unable to dilate in the situational demand. So there are three main forms of angina. There's chronic stable angina, that's usually triggered by exertion. Variant angina, which is the vasospastic type, and unstable angina. So let's look at how medications work to reduce and prevent this. So again, we talk about the factors that determine angina, such as oxygen demand, heart rate, myocardial contractility, intramyocardial wall tension, and that is affected by preload and afterload. Oxygen supply is a big factor. So oxygen demand, the things that affect that are the things listed under oxygen demand, and then oxygen supply, the things that affect that are myocardial blood flow. So the oxygenated blood has to get to the muscle, and the degree of perfusion, which happens only in diastole. So here's a nice little video about stable angina from the British Heart Foundation you might find good. So in that video, you might notice that there's a reference to number 999. That is the same as the equivalent of 911 in the US. This particular video is from the UK. So the triggers for angina, as you may recall, are emotional excitement, large meals, cold exposure, coronary artery disease, and then variant, that vasospastic angina. Quite often it's smoking that really leads to that. And a person usually has other vasospastic conditions as well. So the different types of angina, we've talked about some. One thing that's not included in this list is the microvascular angina, which is kind of a newer categorization. So stable angina is a chronic condition typically. Variant angina is also something that can be typically managed on an outpatient basis because it doesn't escalate quite often into a heart attack, whereas unstable angina is a medical emergency. That's when a person has chest pain at rest, new onset exertional angina, or intensification of existing angina. So what do you do for treatment of unstable angina? So you either maintain the oxygen supply to the heart or you decrease the oxygen demand. So that's what these drugs are trying to do. So nitroglycerin, typically the order is 3 doses sublingually every 5 minutes in tablet or spray. And it can be given IV also if persistent ischemia or hypotension occurs. A beta blocker, usually to give in a unstable angina situation. This is the emergent situation. Usually the first dose is given IV if chest pain is ongoing. There's supplemental oxygen that's given, IV morphine for pain, and then an ACE inhibitor is also given. There are some non-drug treatments for angina management, which include, this would be for chronic stable angina. You might try to avoid factors which bring on angina and decrease the risk factors. So there are 3 prongs of treatment for unstable angina. I'm going to back up here. Unstable angina. And that includes anti-ischemic therapy, such as nitroglycerin, oxygen, morphine, and an ACE inhibitor. Antiplatelet therapy, which includes aspirin and clopidogrel. And anticoagulant therapy, which includes heparin. So now let's look at treatment for variant angina. So the initial therapy is usually a calcium channel blocker or a long-acting nitrate. If those don't work by themselves, typically short-acting nitrate is typically, if you start with the calcium channel blocker, then you would add the nitrate. If the combination fails, a coronary bypass graft may be indicated. And beta blockers don't really work in this condition. So this is one of the exceptions in the usual treatment of angina. You don't use beta blockers for this one. So here is just a table that illustrates the different types of drugs that are used for the management of stable and variant angina. So just comparing those two. So in stable, as you know, there's nitrates are used. They decrease oxygen demand by dilating the veins, which it decreases preload, so the heart's not working as hard. Beta blockers decrease oxygen demand by decreasing the heart rate and contractility. Calcium channel blockers decrease oxygen demand by dilating the arterioles, which decreases afterload. So this all makes the heart not have to work so hard. And then that second line drug, ranolazine, which appears to decrease oxygen demand, possibly by helping the myocardium work a little more efficiently. Now, for variant angina, you use nitrates with the purpose of increasing oxygen supply by relaxing the coronary vasospasm. So it has a little bit different action in variant angina. Beta blockers are not used, but calcium channel blockers are, and that increases oxygen supply by relaxing the coronary vasospasm, and ranolazine is typically not used. So there are just a fewer options for this type. So let's look at nitrates. Nitroglycerin is the prototype drug. It's used in stable and variant angina. It's a vasodilator. It acts directly on vascular smooth muscle to promote vasodilation. Its use in stable angina decreases oxygen demand by decreasing preload, thereby making less wall stretch, so there's less pushing, more or less ejection that needs to happen to get the blood out. So this is interesting. In variant angina, it works to increase the oxygen supply. So on the other side of the equation, by dilating the vessels. So it comes in a million different formulations. And one thing to note is people do develop a tolerance to the effect. That's why with nitro patches, they're on for a period of time and then removed for about 12 hours. So beta blockers, such as metoprolol or propranolol, they also work to reduce myocardial oxygen demand by slowing the heart rate down. So there are different types of beta blockers. There are 3 general groups. The first generation agents, which are non-selective beta blockers, such as propranolol, which blocks both beta 1 and beta 2 receptors. And second generation agents like cardioselective beta blockers, such as metoprolol, which blocks beta 1 receptors only at usual doses. And third generation agents, which are vasodilating beta blockers, which may be cardioselective. So the thing about these drugs is you need to start low, very low, and go slow, and taper when discontinuing. So the adverse effects of these drugs are bradycardia, decreased atrioventricular conduction, reduced contractility. For the first generation beta blockers, like propranolol, you can have asthmatic effects. They're used with caution in patients with diabetes and insomnia because it can enhance hypoglycemia unawareness. Insomnia can be a problem, depression can be a problem, and bizarre dreams and sexual dysfunction. So sometimes these drugs are not well tolerated. So calcium channel blockers, such as verapamil, diazepam, and nifedipine, are very widely used. Verapamil is used a lot. It blocks the calcium channels in the vascular smooth muscle. It's used for stable and variant angina both. It has adverse effects, such as dilating its adverse effects are dilation of peripheral arterioles, reflex tachycardia, hypotension, beta blockers, bradycardia, heart failure, and AV block. So let's go on to look at the action and primary indications and significant drug interactions for anti-anginal agents. So here's the drug card for nitroglycerin and how it works. It works on the smooth muscle to create vasodilation. They work on the nitric oxide in the present, which is a vasodilator. It has an effect of vessel dilation. It's mainly used for acute and sustained management of stable and variant angina. It's contraindicated with drugs for ED, such as sildenafil, like Cialis. It's because it has an additive effect. The significant side effects are headache, low blood pressure, especially if a person's not tolerant to it, can have reflex tachycardia because the blood pressure drops so low. Person develops tolerance, and usually you can get rid of the effect of tolerance just by holding the medication for a brief time. The way you tell if it's working is if the chest pain is relieved. And the comments about it is that it has a very rapid onset. That's why it's so useful in managing angina. And it has the sublingual tablets and spray have a really short duration, 5 to 7 minutes for sublingual tablets. That's why you repeat them every 5 minutes times 3. So here are the myriad ways which this medication is formulated. So it comes in short and long acting formulations. It can be given in a patch. It can be given as an ointment. It's called nitro paste. And you just squirt a certain amount on a little strip and slap it onto somebody. And it can be given intravenously also. So one thing to know about long-acting preparations, if you discontinue them, they should be discontinued slowly. They're, as I said, the main uses for these drugs are for acute anginal management, or sustained anginal therapy. It also can be given IV before surgery to control blood pressure, and sometimes is used in the treatment of heart failure with myocardial infarction. So let's look at beta blockers. So the prototype for this group is metoprolol. It blocks beta-1 receptors of the heart muscle, competes with catecholamines, reduces the SNS effect, and suppresses renin activity. It decreases oxygen demand of heart muscle. So the main indication is for hypertension, heart failure, and long-term treatment of angina. So it's not something that's going to acutely get rid of chest pain. Contraindications, hypersensitivity is a biggie. If a person's in cardiogenic shock, you wouldn't give it. If the person has bradycardia already, you wouldn't give it because it slows the heart rate down. And certainly, if there's conduction issues like AV block, you wouldn't give that, or sick sinus syndrome. Also, pheochromocytoma, which is a tumor that secretes catecholamines. You might avoid it, and severe heart failure shouldn't be discontinued abruptly. So here are there are some drug interactions listed here. And it's important to know that it has an additive effect with hydralazine, and verapamil has an additive cardiosuppressive effect, which results in heart block. And its effectiveness is to decrease heart rate, cardiac output, automaticity, cardiac oxygen demand, but you need to be on the lookout for worsening failure because it can push people into heart failure. Calcium channel blockers, verapamil is the prototype. I guess I don't need to read all this to you. You can read it to yourself. So there are the primary indications for angina, essential hypertension, and cardiac dysrhythmias. It's a good medication for that. Verapamil is especially used for rapid heart rate dysrhythmias. It's contraindicated with beta blockers. It can lead to hypotension, although they are given together quite often. Can cause bradycardia. Also, any kind of upper heart conduction blocks. Some interesting side effects is gingival hyperplasia and eczema. And you know if it's working if the arterial pressure is decreased, if there's a decrease in heart rate, and decrease in cardiac irritability. Ranolazine is a new class. Hasn't tested out to be that great, so that's why it's a second generation drug. And it has the bad effect of causing QT elongation. So it can be combined with first-line agents if there's an inadequate response to them. So here is a question which you can look at. Talks about a common side effect of these medications. So how do you know if these drugs are working? The patient says that they have less incidences of angina or they are less intense. There are minimal, the person is able to tolerate the medication with few side effects, no dizziness or headaches. The person is able to maintain their functional status. They're able to participate in recreational activities and social activities and work. Also, these drugs work to prevent MI and death, and they reduce cardiac ischemia associated with anginal pain. So here's some nursing diagnoses and some outcomes that you can look at for angina. So the two biggies are activity intolerance and decreased cardiac output. So those are two good ones, which you can tuck away in your mind. So just to clarify the guidelines for chronic stable angina, the person should have antiplatelet drugs, aspirin and clopidogrel. There should be an ACE inhibitor that's ordered. They particularly like ramipril because it all has beneficial effects. I mean, it's better tolerated in diabetics, has fewer side effects. Anti-anginal agents are given. This is on a long-term basis. This is treatment on an ongoing basis. This is not acute treatment. So there's long-acting anti-anginal agents. And then you can have sublingual or short-acting nitroglycerin for breakthrough chest pain. And of course, risk reduction, like stopping smoking, controlling cholesterol, controlling blood sugar, and being more active. So that is it for that one. Thank you for listening.